Hello, everybody. Thank you for joining us in such a timely way. This is part 2 of our buprenorphine talks discussion and meant to be much more informal. So maybe for the folks who are already here, if you want to write down in the chat your name, where you work, any questions you have or experience you have with buprenorphine. And your role, that would be amazing. And we're just going to give people a few minutes as folks are logging on. So pop your name in the chat. Here, maybe I'll do that. Yes. Thanks, Ken. Gold star.
I can follow directions.
I love it. I love it. I love it. Carlos is waving. Hi, Carlos. You're muted, though.
Oh, yeah.
Oh, you're muted again. But welcome to share. If the chat doesn't work, that's okay. We've got Callie.
I retired. Thank you.
Retired to the VA. Oh my God! Thanks for joining us. And
I paid my dues. 30 years shoveling snow in Boston.
Yeah. Well, I hope you're somewhere warmer. Thanks everyone who, braved the snow last week, and then we decided to push it back a week, knowing it would have been a little bit crazy. All right, we have Rachel here from OBGYN from Salem. Welcome. Eric at MBHP, Jennifer, MP from Brookfield, Primary Care, Jody, nurse. Oh my God, we have such a great crew here. So I'm Jessica Gray. I'm a family med addiction doc and one of the MCSTAP consultants. And I have actually a second MCSTAP consultant, maybe even a third, but Phoebe Cushman here, another wonderful addiction doc, internal medicine. And so my goal here is to really give us the opportunity to slow down a bit, hear what questions you have, either whether cases that you're struggling with or any sort of things around buprenorphine that you would want answered. I do have a PowerPoint that I'll share and help to navigate questions if folks are more shy in this group, and that's okay. But otherwise, really wanted to make this an opportunity for folks to come together and ask questions and learn. And so thank you everyone for putting your place of work and who you are in introductions. If you want to come off camera, awesome. If not, that's fine, totally fine too. And I am gonna just share. Nope, first let me do this. And let me do this. And Phoebe's gonna be amazing and help me monitor the chat. So if you don't want to come off mute and you want to ask questions or dive in, again, pop your questions in the chat.
What's the order you'd like to do things in, Jessica? Do you want
to do
your PowerPoint first, or do you want to take questions first, or it doesn't matter?
Yeah. So what I'm going to do is I'm going to just get to the, that's a great question. So I am just going to remind everyone who we are and why we're here. For MCSTAP, you've seen these slides before, but join us for either one-on-one learning or consultations or any of these didactics that we host. And I am going to skip right to, our team. We're here. We really want to help people feel comfortable treating pain and substance use disorder. And so please call us, share with your colleagues. And you can receive credits for this webinar. And so more information will be sent by email after that. All right. So just to level set, right, our group discussion, our goal is to foster safe, interactive learning environment. Please, turn on your video if you can. mute until, so we don't have to hear you chewing lunch or something. And then ask your questions in the chat, and you can either raise your hand or Phoebe, and Phoebe can help, let me know if I can't see you on this Zoom or the Teams. And then again, remember this, everything needs to be de-identified, so please don't share patient names or any of those informations. And yeah, this is an informal time to really ask your questions. And so these are some of the topics that folks have wanted to hear about in the past, or the things that I'm happy to talk about, or we're happy to talk about, including low-dose buprenorphine inductions with agonist continuation, giving some more information about high-dose buprenorphine inductions, a case from 7OH, talking about what happens when people use alcohol while on buprenorphine and what should you do. What does it mean to inherit a patient on buprenorphine? Think about injectable buprenorphine questions you may have, or even sort of perioperative. And so I am gonna sort of let you guys percolate on those questions. If anyone wants to have has a special question around one of those topics, want us to dive in first, or are there other topics that you guys want to hear about after on buprenorphine? Ken, did you sort of seemed eager?
No, I love that list that you just showed us. I think probably a lot of people on here have some questions and experience and scratching of heads when we encounter some of those issues. Particularly for me, it's sort of the methadone to bupe transition, right? And how to do that well. I have a list of a handful of other questions that maybe this is a good forum to ask, but I wondered, should we start with that one, or should I ask away?
Let's get all the questions out at the beginning, and that way if other people can.
Okay. So yeah, my second question then was about kratom use and transition to Suboxone. Any thoughts about how to do that? What dosage range typically works? Third question is, I saw actually on an ASAM forgetting the term, but the board where people post questions and answers a number of days ago about the possibility that Brixadi might be coming out at a 160 dose. And I wonder if you know anything about that. And because again, in my limited experience, I mean, the 128s work pretty well. And I just wonder, is there room for a 160 on a monthly Brixadi dose? And that's sort of the main questions I had right now. I'm sure I'll come up with others, but that's a good start.
Those are wonderful questions. Everybody else, are there questions that you have? Are there topics that either are listed or Ken raised that you want to elevate? If there are things that, we're in a mixed group here, so some people may have a lot more experience with buprenorphine and some people have a lot less. And so I also want to make sure that folks who are maybe doing this for the first time or haven't done a lot of it or work in different settings other than sort of low threshold, bridge clinics like Ken is at MCSTAP, and please don't be shy and let us know, and we're happy to do that too. So I am going to switch to my presentation unless people come off mute and let me know, and I can only see part of group. Okay. So while people are thinking and typing, I will just say, great question around Brixadi. So Brixadi is the sort of newer injectable buprenorphine product. That's probably the easiest one to get done. The newer injectable buprenorphine product that came out in the US, although it's been around in Europe and other countries for a while, but Sublocade had a patent sort of limiting access for other companies to come in. And we can talk more about Brixadi and Sublocade if you guys want, but just what is different about Brixadi than Sublocade is Sublocade has 2 doses, and Brixadi has both weekly and monthly injectable long-acting doses. And but in the US, they stopped at the 128 milligrams, whereas in other countries, as Ken mentioned, they go up to 160. And so I don't have any information. It's a great question as to whether why they made that decision, if it was sort of being conservative, thinking that we didn't need that high a level, or and I haven't heard of anything definitive of getting that level in the US. So I'm happy to look into it, and obviously if anyone else, Phoebe might have heard some more about that. Yeah.
So I hadn't heard that was coming. I heard through the grapevine that was sort of on the docket, but I think it sounds like it's maybe more likely to come now. I guess my thought is sometimes I have patients who are already on pretty high dose bup, and I guess I might just have some cognitive bias because I used the Sublocade brand version of buprenorphine injections for so long before the Brixadi became available as a choice. But I have some patients who I might be like switching from methadone or I don't know. So as you probably know, Sublocade comes in a 300. So it's 300, 300, 300, and then you drop down. And so just in my experience, I find that some people even need to stay on the 300. I guess what I'm saying is there, I find personally that 128 doesn't always feel like enough, but I sort of choose between, if I feel that way, I don't think that 160 would necessarily make a huge difference. I would probably just choose the Sublocade if I have that option, which Mass Health is now covering both. But so I don't know why they, I don't know exactly the answer why 128 versus 160, other than to say that 128 does feel insufficient in some cases sometimes, in that patients report a lot of ongoing withdrawal, way after they haven't even been using fentanyl, or like feeling the need to take a lot of additional films on top of it.
And what I am going to do, we jumped right into the hard stuff, can you guys see my screen? So this is just a sorry, it's a little fuzzy. It's a comparison chart of buprenorphine, of the buprenorphine XR average blood levels, so C average bup at steady state, and versus the sort of peak, the maximum after a single dose. We don't have a lot comparing buprenorphine, Brixadi, which is the newer one that comes in weekly and monthly, and versus the Sublocade long acting. Well, they've all been sort of compared to the sublingual, which is the furthest column on the right. But what you can see here, just to put into some data from what Phoebe was saying, was that the 128, the bolded, right, milligram monthly long-acting Brixadi has an average serum level of 3.9 nanograms per ml. And just again, to put that in context, pre-fentanyl, we thought that 1 nanogram per ml blocked sufficient sort of receptor occupancy had sufficient receptor occupancy to stop cravings, withdrawal, likability of drugs, and that has sort of moved to sort of a threshold of 2 nanograms per ml. And then at our last talk, I shared data that actually maybe 3 to 5, a serum level of 3 to 5 is actually necessary for fentanyl. And so just to sort of put this into context, what a serum level, why we think about this. But so if you look, the monthly, again, apologies for being fuzzy, but the monthly 128 milligrams, which is the highest we have for Brixadi right now, has a serum of serum level of 3.9 versus the 6.3 for the 300 of Sublocade. And then I think that's all I wanted to share from that graph. And then I go to the next slide. Again, as this is what Phoebe was sharing in terms of this is just Sublocade, and each one of those shots in the bottom are monthly injections. And what you see is that the first 2 loading doses of 300, which is in blue, are sort of the same recommended initiation for the Sublocade. So you give 300 the first month, 300 the second month, and the idea is that the medication stacks on itself, and so after 4 to 6 months, you sort of reach, the idea is that you would reach a steady state, which is how I describe it to patients, right? That you might not feel perfectly fine the first month or 2, but sort of give it time. And then what you can see is if you drop down to the 100 in sort of that third injection, and then you continue what we think of as sort of the maintenance 100, right? You can see the sort of steady state is around 3 nanograms per ml, if I'm just totally eyeballing it, versus if you continue with the 300, the serum level rises. And so I just wanted to point those out as we talk. And then now I have to go all the way back to you guys again. Okay, so.
Well, that's helpful to see because clearly there's, an expected difference in serum levels and perhaps retention even down the road after a number of months of the long acting.
Yeah, I think the other interesting thing is that I recently, I guess, learned that you could give both Brixadi and Sublocade, as early as 21 days, and I wonder if the Brixadi is actually, if that'll make it more useful for those super high serum levels, right? That for the harder to reach patients. But does anyone want to vote on Kratom /708 versus talk more about the injectable, or sorry, the transition from methadone to buprenorphine? Karen, you you went on video. I appreciate you. What are you thinking?
Well, I mean, we haven't had kratom yet in the emergency department here, but I have heard I had a similar question as Ken, because it sounds, but again, if the audience wants to do methadone first, I'm good either way. Methadone transition.
All right. Well, I prepped kratom because I also, it's starting to creep up, in patients I care for, and certainly MCSTAP callers are calling about kratom and 7OH. And so hopefully, why don't we start with that? Yeah, I don't know if the Vineyard has, if you're seeing it on the Vineyard, right? And at local stores or anything like that. No. Okay.
Stay tuned.
I know, right? Well, this is unfortunately coming. All right, let me find kratom. My first time also trying to go back and forth. So thank you guys for bearing with me as I go back and forth in the PowerPoint. Let me know if you can see it. Awesome. Okay. All right. So this actually, I decided to share a recent case because I think it's illustrative of what we're seeing. And so this actually really focuses on 7OH and thinking and what we ended up doing for a buprenorphine induction for this patient. So de-identified, this is a 24-year-old construction worker. And just letting you know, I think this is something we're seeing a lot in that line of work. 24-year-old construction
Jessica,
worker.
can I ask you one
Oh, yeah.
foundational question, though, just in terms of this? Please clarify, though, kratom is the actual nitrogyna, I forget.
I'm going to walk through all that.
Oh, okay, good. Okay, because I want to know what's available when you go to the store,
Great question. So yeah, let me present this case and then I'm going to back up and probably not answer all your questions, but give a little bit more background. and then
I think
maybe
you
the
will
hive
answer
mind
them all.
here, and then I think the hive mind here will hopefully share. Okay. No, thank you, but I really appreciate the interest. Okay, so setting the stage, right? So this is a 24-year-old who has been a construction worker, actually self-managing his pain with high potency kratom. So he identifies he is using the term kratom, but really to refer to 7-OH, and I'll talk more about that. And so he has a severe kratom / 7-OH use disorder that he started for managing his pain, and that's because it doesn't show up on drug tests, right? So he has to get drug tested for his construction job, and this was a way to avoid it. Unrelated, he also has an active alcohol use disorder and heavily drinking daily. Doesn't really want to address that right now, wants to address the kratom first. He's also vaping. And so his concern, he comes in, is really escalating kratom or 7-OH use with difficulty controlling his intake. He feels like he's going into withdrawal after 6 hours, and that looks a lot like opioid withdrawal, right? So he describes severe restlessness, rhinorrhea, tearing, GI distress. He gets nausea and vomiting, muscle ache, sort of all the works that you'd think of with opioid withdrawal. He actually in the past had been on buprenorphine naloxone 8-2 twice daily, and so wants to get back to buprenorphine. And he describes his use as 86% pure 7-OH, using a gram, lasts about 3 days, that he buys online. And his goal is really to continue working, and then while he stabilizes his kratom use, and so he doesn't want to go in anywhere, like an acute treatment service. He really wants to sort of do this while continuing working, and then later address his alcohol use disorder. So kratom and 7-OH, 7-hydroxymitragynine. So as Ken was alluding to, kratom is actually Mitragina speciosa. It is a plant leaf, and that contains actually more than 40 different alkaloids. And so mitragynine is the primary alkaloid in the kratom plant that takes up about like 60 to 70% of the makes up about 60 or 70% of the content. And mitragynine, it's a partial mu opioid receptor agonist. And these funny numbers I will talk about in the next slide. It is a weak antagonist at kappa opioid receptors and at lambda opioid receptors. And it also interacts with adrenergic and serotonergic receptors. And sort of why is this information important, right? As we're thinking about, do we treat this like an opioid, right? It's sort of like an opioid plus, because it has these other, it's not just a mu receptor agonist, it's got these other active properties. And so what is then 7-OH, 7-hydroxymitragynine? That's one of the minor natural alkaloids in sort of the kratom leaf. And interestingly, it also is a sort of breakdown product and oxidative metabolite of mitragynine. So not only is it there in small amounts, sort of as one of the greater than 40 alkaloids in the kratom plant, but then also mitragynine turns into 7-OH sort of in the process of metabolism, which I thought was really interesting. And the important thing about it is a much higher mu opioid receptor potency than mitragynine kratom. And then the other alkaloids actually have more alpha adrenergic properties, which is why for kratom plant you actually see both sort of the pain relief as well as the sort of stimulant-like opioid effects. None of these are FDA approved, right? Kratom is not FDA approved or studied for therapeutic use. We really have limited safety trials and really limited understanding about what a therapeutic dose of kratom or 7-OH would be. And what we're seeing, and I think we're getting a lot of calls from MCSTAP about this, right, is that sort of self-experimentation is becoming more problematic. And there is increased availability of these highly concentrated kratom extracts that really is across our state. So ChatGPT and I geeked out together. because I wanted to know, like, what are those sort of Ki values? Like, what do those affinities really mean? And so, what does the mu opioid receptor binding look like for kratom versus other opioids and 7-OH? So, what I found was that if we think about buprenorphine, well, first of all, I'll say in the middle, morphine is really sort of that's our reference, right, for binding affinity and duration of action. So if we look at buprenorphine, you can see that it has a lower Ki, which is the sort of binding coefficient. And so that means that it has a higher affinity, which we know in the way buprenorphine works. That's why you get precipitated opioid withdrawal if you take it too soon after a full agonist. So buprenorphine has, this really low or tight binding affinity. It's a partial agonist, and it has this long acting, right? It's long acting in general, which is what allows us to get people on it and keep people safe. If you look at fentanyl, it also has a low Ki or a high affinity for the receptors. It's a full agonist. We know it has a short plasma half-life, but as we're seeing in illicitly manufactured fentanyl, right, along tissue, it stays and builds up in the tissues. And then morphine, again, this is sort of the standard reference. And then if you look at the 7-OH and the mitragynine or the kratom, you can see 7-OH has a, I don't know, 10, 20, 70 fold, however you want to say this, right? It not crazy different from morphine, right, in terms of its affinity. So it's got a less affinity than buprenorphine, which means that buprenorphine would be effective, right? It's less than fentanyl, so less potent, right, than fentanyl. It's a partial agonist, and its duration is hours, versus the kratom plant, mitragynine, really has a very high Ki, so it's like it's a weaker opioid. So it's a weak partial agonist and has a longer duration of action. And so in terms of 7-OH, again, to Ken's plant of a question, right? So the 7-OH is a powerful psychoactive compound, occurs naturally in very small amounts of the kratom plant. Thank you, FDA, for this info on this slide, right? Again, as I said, the products are derivatives, and they're falsely marketed as kratom. So that's the concern, is that people are going to gas stations, to corner marts, and thinking they're getting this kratom, which has the low affinity and is sort of a milder opioid, but actually they're getting 7-OH. And so the FDA wrote, to be clear, the kratom plant leaf, which contains trace amounts of 7-OH, has been consumed for centuries. It's not our focus in the FDA. And Martin Makary, the Commissioner of Food and Drugs, last summer put out a warning or request to colleagues saying, I'm writing to warn you about an opioid that few physicians may be aware of, 7-OH, found in trace amounts, but not our focus, right? The concern is the 7-OH. And concentrated 7-OH products have exploded in popularity, right? So we're getting them in vape shops, gas stations, corner stores, online, and up in the top, you can see sort of all the ways that it's marketed to the population. So there is talk of regulating this, and the FDA is, working to try to do that. But unfortunately, I have yet to see any change in sort of access, and I'm just seeing more and more people who are unfortunately either thinking they're getting kratom and actually using 7-OH. And so I'm going to pause there before I go back to the case, because I'm happy to talk through the case. But in terms of maybe just having a conversation, where are you guys?
I have a question.
Yeah. Yeah, please. And I'm not an expert on this. This is just me geeking out.
So I've had multiple patients over the years who have, like, I've used buprenorphine for kratom, and I don't know that I've had people, whether some of those people might be 7-OH or not, but is there a phenomenon whereby this higher affinity is causing it to be much harder to get people onto buprenorphine?
Exactly.
Yeah.
Yeah, I don't know if anyone else is seeing this, but this is exactly what I'm seeing, is that we had these several years of, okay, there isn't much in the literature on managing kratom, but we are seeing some people have kratom dependence and diagnosis for kratom use disorder, and we are treating it like opioid use disorder. They generally, they're like very limited case reports in the literature show that, okay, people can be induced usually on like low to moderate doses of buprenorphine and do great. There's like, I think, an N of 1 in the literature on naltrexone for kratom. So yeah, it felt like, okay, this is a little bit easier than fentanyl, and it sort of met the sort of moderate use disorder in terms of thinking about like severe opioids, and we were able to get folks onto MOUD for that. I don't know if that's the experience that other people had seen. And then I would say in the last, I don't know, 6 months or so, more and more actually mixed up colors were sort of identifying it. And then now I'm seeing a lot in our Bridge clinic where folks maybe started with kratom, maybe didn't realize at first that they were moving on to the higher potency, and then just having like really skyrocketing use, and in terms of hundreds of milligrams a day, spending a ton online, and having an incredible difficulty getting onto buprenorphine.
Does it cause precipitated withdrawal? Like, is it sort of similar to getting people onto buprenorphine from fentanyl, or is it too, like, is there a pattern to the way in which it's hard, or too soon to say?
Yeah, that's a great question. I mean, I think and that's why I went down the rabbit hole of what are the PK, like what are the affinities, right? Again, this is, at this point, I'm speaking anecdotally, right? I don't think we certainly don't have anything, significantly published on this. And so in terms of, based on the affinity, right, and the binding affinity, buprenorphine is still stronger, so it will push off buprenorphine. It's a shorter acting, than sort of the kratom, and it's, and I would say the sort of dependency is more severe. So in many of those ways, it does fit the fentanyl-ish sort of pattern of challenge of getting people on. I'm finding also that it's not quite as difficult as fentanyl in terms of precipitated. I'm not seeing that as in terms of precipitated withdrawal. It's like the discomfort and the need for very high doses of buprenorphine are what I'm seeing to stabilize. And I think we're probably missing some of the other, properties that don't make it a pure, opioid agonist that are contributing to sort of to what's going on. Okay, so let me just finish this and then we can get to other questions. Share my screen again. Can you guys see? Okay. All right, so this is just a timeline. So 7-OH to buprenorphine. So the first day that this patient came in, wanted to get on buprenorphine, wasn't in sufficient withdrawal. So he was given a prescription for buprenorphine to potentially start at home as a home induction, but then didn't come back. Ended up, calling, outreaching. So let me back up. If this person presents to your clinic, I think it's important to, in the counseling, say, right, that we have limited evidence on treating 7-OH, but that, this patient had been on buprenorphine in the past, and so sort of, so that's helpful to know that this is something that they had done well on, but also the hope is that, right, because of the lower mu opioid receptor binding, that we actually wouldn't need to wait for the level of withdrawal that we see with fentanyl, for example. And so at that initial visit, as we counseled sort of through the options for this patient, the patient actually wanted, was either thinking of like a direct to inject buprenorphine, right, with the idea that sort of the gradual onset with buprenorphine, if he was in, starting to be in mild withdrawal, but that also he's probably could do well with a sort of traditional or sort of a sublingual buprenorphine induction, just given the weaker binding of the 7-OH. And so that's just, I just wanted to sort of frame the conversation, right? This is not like, it's not a standard conversation for classic opioid use disorder. We do want to document that this is an evidence limited zone. So anyway, so back to this case, he then represented 5 days later, uncomfortable. He said his last 7-OH use was about 12 hours prior and was having emerging withdrawal, and didn't want to actually start medication, then wanted to go home first. But the plan was to take, at that time, this is all different providers in our clinic, where it was to start with 4 milligrams and increase to up to 16 milligrams a day. And then he did not, and he was supposed to come the next day, he didn't. At home, when we met him on day 7, he shared that what happened was that he sort of last used on day 5, right? So at 9:30 in the morning. On 9:30 in the morning on day 6, right? He said, okay, I'm done. Like, I'm done with my supply. That's my last use. He then waited till about 3 p.m. when he was getting uncomfortable, and he started buprenorphine, and he sort of took everything under his own control. And what he did was he started to have sweating, diaphoresis, muscle twitching. He was describing, goosebumps, feeling really like he was crawling out of his skin, and took 8 milligrams times 2 of buprenorphine films in those next couple hours between 3 and 6 p.m. Ended up going to sleep. He actually woke up at around midnight, feeling very uncomfortable and severe withdrawal. So he was describing the restlessness, the GI distress, like kicking. He described it as like the worst withdrawal of his life. And so from around midnight to 8 a.m., he actually essentially did a high dose buprenorphine induction. He took 5 films of buprenorphine overnight, totaling, 7 films of buprenorphine, right? Oh, did I lose you guys? No, okay. And then he presented, this is where I met him, he presented on day 7 to clinic, and shared with sort of how he had self-induced onto buprenorphine and really what is a high dose induction, right? And by 11 a.m. he was starting to get uncomfortable. And so at that point, we actually gave him the injectable buprenorphine, the Sublocade 300, with a plan for a loading dose a week later, and gave him extra films. And so I wrote this case up before he came back for that second weekly buprenorphine, or the second loading dose of Sublocade. He got it. Since then, he's gotten it and feels really a whole lot better. And so I think the learning points here, again, this is one case, but what I think it really illustrated was just how uncomfortable this 7-OH withdrawal is. Like it really does rival traditional sort of fentanyl and other opioid use disorders. As we think about sort of high dose buprenorphine inductions, the concept is someone's not going to stay on like 60 milligrams of buprenorphine, but actually that first day they sort of flood their receptors with buprenorphine, and then by day 2 they're back down to a more sort of moderate dose. So it's not in the sort of studies on high dose inductions, right? there were some people who got up to 64 milligrams on day one, sort of this loading dose, and then they get down to a lower dose. So just wanted to, I think, highlight a couple of those, but I would love to pause and just, ask other folks their thoughts on this.
So one question I have is, it didn't seem to you, did it, that it could have been precipitated with
Ken, you broke up. Can you start again?
Sorry, I was just wondering if the severity of his withdrawal was just plain old kratom withdrawal, 7-OH withdrawal, and not precipitated by the bupe that he had taken, just because the timeline didn't quite fit. Is that what you're thinking?
Yeah, I don't think it's a great question, right? So the question is sort of, if his last use of 7-OH was at 9:30 in the morning, he then took 16 milligrams and actually felt better, went to sleep for a couple hours, and then woke up and withdrawal. Like that doesn't, exactly. That to me really sounds like natural withdrawal. It doesn't sort of fit the criteria for precipitated opioid withdrawal from buprenorphine.
And the other question, explain, if you would, your thinking regarding the second dose of Sublocade 1 week after, because I like that. It really was a cool idea, but let's hear how you thought about it.
Yeah, so this has been a game changer for us. I don't know. So Sublocade, when they actually changed their prescribing recommendation. So now instead of every 4 weeks, you can give that second loading dose. So the second 300 can be given on day 8 after the first one. And their studies really show that getting to a serum buprenorphine level faster in the era of fentanyl actually allowed people to stabilize better. And so we've actually been doing sort of a lot of that for folks who are coming from fentanyl and who really sort of need to get need that sort of initial boost in steady state. And it's sort of as we talk to patients about this really 4 to 6 month period of getting to steady state, it just sort of shrinks that a little bit so people can get on it faster. That's not for everyone, right? I sort of give people the option of, we can see you in a month, or if someone's, if I know they're going to be likely to not be, perfectly comfortable that first month, I'll have them come back early and say, let's at least check in at week 1. And if he was feeling fine, we would have just, continued to monitor. Yeah, but that is covered by insurance. Yeah.
And in this case, though, given that it was kratom, but you thought about it because of the severe withdrawal and the high loading dose he needed to get comfortable on day 1 or so. Is that right?
Yeah, and just to sort of speed that. Yeah. And I wasn't the one to see him for the second dose, so I know what happened. I know he's feeling great, and I don't. More to come on that. If there aren't, I want to turn to, there's great stuff happening in the chat, Phoebe. I don't know if you've been moderating the chat, but there's some Vanessa, thank you so much for all of your questions. I think we're gonna pivot now, just because I'm mindful of time and we have 15 minutes left together, but could geek out on this stuff a lot longer. So Vanessa was asking a great question, which is, on folks who are apprehensive about oral buprenorphine, do they do better on injectable? Phoebe, do you want to, you already wrote this in the chat, but do you want to sort of talk us through your thoughts?
Okay. Yeah, I was just, Vanessa had a question about injectables, and I wrote it in the chat because I wasn't sure we would get to it, but it's sort of a big question, like, injectables, like I mentioned, if you want to learn a lot about injectables, or you want to learn, like you want to sort of start doing them, there's a really great, BMC does a really good talk on them every once in a while through the Graykin Center. But so the traditional, like sort of historically, the way we used to use injections is people who were already on the sublingual films, we would start the injections like 8 days later or something like that. And now there are new protocols originated in the ER, but they're Mass General and BMC are using them, where you can actually start somebody on buprenorphine initially with the injection. And the idea is that you're taking advantage of the fact that you're getting the medication doesn't reach its full steady state instantaneously. And so it's kind of giving you its own induction in your bloodstream. So there's protocols for that. And then I mentioned that, like, sort of in my head, I think of like, why bup injections? Like, I think that was Vanessa's question, like, why would you use an injection? And so I have some patients who've been like stable on bup, the sublingual, for years, and they're like, I'm so tired of taking this. I'm so tired of going to the pharmacy and filling it. They might say that it reminds them of their addiction because everything else in their life, like, they've gotten everything back together. I have some people who have trouble, like, they don't like the sublingual. They don't like dealing with the stuff in their mouth. It might make them nauseated. Obviously, the injection bypasses their GI tract. I have another group of patients who, who I recommend it to, who are really unstable, who, like, they can't get their act together. They're always missing appointments. They don't bother to fill their meds. They're always using fentanyl on top of the buprenorphine and not remembering to keep taking the buprenorphine sublingual. And if you give the injection, then it's at least in their bloodstream. And I have patients who, like, every time that they show up, I'm like surprised they're alive, but they come in every month for their injection because they know, so they do that, even though they're still using on top of it. So that's like a very big sort of big picture, like why you might use the injectables, but they really are great. And there's going to be, I definitely have some patients, because I work in a methadone clinic. I have some patients who do better on bup injections than they did on methadone. So it's just another great tool in the toolbox.
Thank you so much, Vanessa. These are not elementary questions.
No.
These are actually wonderful questions, and we are also happy to support you in your, as you're growing the OBAT clinic, and so we can talk offline. We're happy to support you at MCSTAP. But I do want to highlight what you shared, which is just like the fact that a lot of people just want to use it as a tool of essentially like a withdrawal management tool, right, and come off of it. And so let me just I can share my screen again, and we can just spend a few minutes, because the other version of that is like, how long do I keep prescribing? It's a question that I get a lot. And so, for example, this is a patient who is 49, started on buprenorphine at a bridge clinic, and you took over a few months ago, right? And then the patient asks, how long do I need to be on this medicine? And so we'll go over we can go over the literature, but also think about ways to talk to patients about this, right? And so what we actually know is that tapering buprenorphine, so this is a study from 2014, actually compared to maintenance, even so there's detoxification, even tapering over a long slow period leads to worse outcome in terms of treatment retention. And you can see here's where in the study, right, they started the taper at 6 weeks and ended it at 9 weeks, and the drop off is pretty significant. There are a couple ways, and you sort of have to know your patient to figure out what's the best way to sort of approach it with them. I really like this chart from 2000, which talks about, from NIDA, which really sort of frames the chronic disease model of addiction. And you can see here comparing this like concept of relapse, like, right, what does it mean to relapse in type 1 diabetes, right, or in hypertension, right, to sort of have a return to the active state versus being in remission, right? Or having an asthma flare, and you can see where drug addiction, right, sort of right in the middle there of like of chronic diseases where you have these sort of flares, right, or relapses. And so just reading this, right, the relapse rates for drug addicted patients, not a term we use anymore, are compared with those suffering from diabetes, hypertension, and asthma. And relapse is common and similar across these illnesses, as is adherence to medication, right? So therefore, substance use disorder should be treated like any other chronic illness, with relapse serving as a trigger for renewed intervention. And so I think that's a nice frame. I usually turn the question back to patients, which is understanding, like you said, like, why do they want to get off, right? nobody likes to be on a medicine, right? You have a chronic disease, no one likes to be on a medicine. And, whether it's for your thyroid, your diabetes, or your high blood pressure. So like naming that. And also the stigma, like you said, which is around being on medication for an opioid use disorder. And I do think that the injectables there do serve a nice purpose, right? From sort of making any medication easier to take, but also being less or more private, I should say, sort of like injectable contraception, right? Or right, that it's sort of like not as maybe in public to if people are concerned of that. And I think that I usually turn it around. So what I usually do is turn it around to folks if they say, how long do I have to be on this? And I actually say, well, how long have you been using, right? How long has sort of your brain been altered? And they're like, a decade. And you're like, okay, right? So let's sort of think about the realities is that a month, a week, 6 months really isn't going to give your brain enough time to heal and to be able to live your life and function. So these are, I feel like, constant questions and sort of navigating. But the reality is, just from other data, right? We again, just like other conditions, there's really high rates of treatment discontinuation. And so I think those are, I guess some of my thoughts in terms of how to navigate. And I think one thing to consider just for you is really finding folks with lived experience from the Latinx community, right, who are on MUD, have been successful with MOUD, right, to sort of hopefully reduce some of that of that stigma. Yeah. Other thoughts from other folks in the group that have had success with these conversations?
Yeah, I've had that conversation a few times with people in our bridge clinic. I wish it would happen more often, but again, people are more often so highly unstable that we don't get to that conversation. But I usually, I love the idea of talking about, well, you've been doing this X amount of years. Let's, you can take this as long as you want to, and I think it's a good idea because of the safety of it. But for those adamant about really at some point coming off of it, do you have the naltrexone conversation with them as well? And if so, how's that going for you? I've tried that a couple of times. I just wonder if you've had more experience.
Yeah, no, I think so. What is the plan after? Because I think often when people get off buprenorphine, that just means the end of treatment. And so like really helping them see that before you understand that that's their goal and so what would it look like to really then have a robust treatment plan post buprenorphine? What community supports are you going to engage with? What are you going to do for overdose prevention? I think keeping some films locked, safely at home for should you have cravings or want to get back on it. I think are important, of course, naloxone, right? And just really knowing that, right, your tolerance goes back to zero, right, when you are off medication. So you're really at very high risk for overdose. And yeah, I think, again, I have a pretty high acuity clinic, so I don't see a ton of folks who are switching to the naltrexone once they're sort of in longer term remission, but I offer it to everybody, and some do, eventually take us up on it. But I think really is what does the controlled substance gets people in, right, to then like do the work of recovery and stay connected. And so I think that's the part that we need to figure out is really like how do we then keep people engaged in substance use supports. Do I know what percentage? Oh, sorry, Karen. While
I was just going to echo what you said, Jessica, about the chronic illness, and it's really helped me in my practice too, just as far as like stigma and just trying to like really help people feel like meet them where they are, because it's really, I think it's really surprising when patients sometimes think of it that way, and I think it's a great opportunity when you talk about the chronicity of the disease. So just wanted to kind of echo what you said.
Yeah. Gosh, yeah, especially in the ED, right? When there's so much reason to feel like, so much stigma, and people are coming for other chronic illness flares, right? I love that so much. Great question from Eric in the chat. Do we know what percentage or how many of our patients also avail themselves of peer coaching? Yeah, a really high percentage, I think, of patients in places I work connect with our peer coach. So I work in a perinatal clinic where the moms really appreciate having someone with living experience working with them. And then, at our Bridge clinic, I would say the vast, many say hi, engage a little, a little to a lot. Whoa, that's my earbud. Can you guys still hear me? I think the folks who don't often may see themselves as sort of having be less less experienced or connected with the recovery community, may not sort of understand what a coach is or does, right? It's not a therapist. And so I think explaining I often find it's really helpful to sort of, for those who don't know or have, everyone who's had a coach is like, sure, I'll say hi to someone, right? Unless, in my experience, unless they already have a coach and they're like, no, I'm set. But I find that for folks who are sort of reluctant, that really sort of having a focused thing to discuss, like oftentimes it's thinking about, I talk about like your toolbox for recovery, and so I talk about the medicines and I can do a little the other things, but really if you want to think about trialing different meetings or sort of understanding the recovery supports in your community, like let's talk to our coach. They're an expert, they're really experienced in this, they can give you some recommendations to make it not feel like an overwhelming sort of ask to connect and sort of be low key. So I think sort of having, and then letting the coach know, like, this is the specific question that they have, can sort of facilitate. And if your coach is good, right, that will then start a relationship. In terms of where to connect to coaches, there's wonderful, every community now has these recovery resource centers. And so it's one great place if you don't have them in your system to recommend patients connect. Yeah, other thoughts from other folks on the call? And Eric, other questions about that? It's a great way to end, guys, because I feel like we talk about the medicine so much, but really like the secret sauce of, in my mind, of being safe or entering recovery, meeting whatever goals you have, is really community and connection. And so I do think sort of ending with the important role of peers. And now there's work in the state to have it be reimbursable. So I think for places where that hasn't been an option, I think, right, there's hopefully Mass Health and the state are coming up with a way for that to be a reality for care sites.
Yeah,
Vanessa, where are you? Oh yeah, I'm curious where you're.
I'm in Boston. I'm at Casa Esperanza in Roxbury.
Oh, we really should talk.
Yeah. So yeah, I'm the first provider here for the psych department, and they want to expand and do OBAT, but I need to learn more about OBAT. We've been reaching out to Greg, and they are super, super busy. So I'm just getting.
We got you at MCSTAP. Yeah. Send us your email. If you want to put your email in the chat or something, and we'll be happy to be in touch. Chris Shanahan is on here. He's our medical director, and I know that I'm sure his ears are perking up unless he's in clinic. And
they are definitely perked up, and I'm thinking mentoring. I'm thinking mentoring here. That's what I'm thinking.
Yes, I would love that. Yeah, I'm a psych NP. I've been a family nurse practitioner a bit longer. and mostly worked in clinical research. And I worked at Fenway Health for 8 years in the PrEP trials. So I'm familiar with this, with the folks here, our population here, but it is a great pleasure to be able to serve folks who are Hispanic, but also I get the challenges. They don't want to they don't want to take these things long term. They come to residential and like a month later they're already saying, I want to get off. When can I taper? And I've tried all of these different explanations. You have type 2 diabetes. What would happen if?
Yeah, totally. Well, I'm realizing we're at time. So I think I want to, I'm so excited. We're so excited to help support you. B, thank everybody for coming today and are rescheduled. If there are things that you, want, topics you want covered better, ideas for future didactics, ideas for this future didactic, can you guys drop us an email? We would love to hear it. We're always sort of looking for ways to better support providers and teams out there in Massachusetts. So thanks guys so much. Oh yeah, thank you, Amy, for actually putting our contact in there.
And then as James Baker says, 1-833-PAIN-SUD. Call us 9 to 5. That's our number. Call us with any patients Monday through Friday. Yeah. You guys are a great group. It's very inspiring to see all of your enthusiasm.
Thanks so much, guys. Take care, everybody.
Thank you so much for being with us. Jess and Phoebe, do you want to stay on for 1 second?
Sure. Thanks, everybody.
And Chris, too, if you want to stay on. So I'll
Amy, we can also move on to a different team. Want me to send a link for a different teams?
Yeah, actually, you know what? Just sign off and sign back on. I can do that. I can, when we do that, well, I'll close this and then we'll reopen.